Well, it's 7:15 and that's our announced start time, so we'll go ahead and begin. Welcome to you. We're happy to have you join us for this session. And as I've indicated, please don't hesitate to type your questions into the chat box or unmute yourself and you can go ahead and ask verbally. I also posted this time the histories, and we'll begin with this first case, which is a 45-year-old woman who noted some pain, particularly as she was reclining on one side of her body, and that led to discovery of a mass that was adjacent to, seemingly, her humerus, and creating some pressure sensations on the brachial plexus, nerve roots, and so forth. Radiographically, this lesion had sort of a chondroid appearance with sort of some rings and a little bit of peripheral calcification. And I've given us two slides to look at. It wasn't completely clear from the radiographic studies what the connection was with the underlying bone, because most of it seemed to be extraosseous, but it was very closely opposed to the cortex of the humerus. And ultimately, its surgery was found to have somewhat of a connection. As you can see, this is a nice chondroid lesion. We have areas of peripheral bone ossification here on this lesion, and a little bit of fatty marrow. In evaluating a chondroid lesion like this, sort of understanding etiology is important. The location was in the proximal humerus, perhaps just slightly distal to the metaphyseal area, or in that general category. So it was probably on the distal side or diaphyseal side of the former growth plate, which would give you some idea in terms of differential considerations. So this is obviously mildly cellular chondroid tissue. It has here a little bit of interaction with the bone, with some apparent endochondral ossification here. I don't think this is truly invasion of the bony spicules, but probably represents endochondral ossification. So much of the tumor here then looks just like either a benign chondroma or exochondroma. But we do have a few areas where we get a little bit of more myxoid change. We'll look at the next slide here, because that has a little bit more of this interaction here. And we see a little bit more of the areas where there is more cellularity to the chondroid tissue. So in examining this, it was apparent that this was probably derived from a osteochondroma, because it did appear to have that connection with the underlying bone. And although osteochondromas are generally considered a benign neoplasm, they can become sufficiently hyperplastic that the diagnosis would shift towards that of a low-grade chondrosarcoma. And because we did have a few binucleate lacunae in here, we did have this area of a little bit of kind of bony necrosis associated with this lesion. And because the overall thickness of this cartilaginous cap in this lesion was so high, we felt that this fit best with the category of a low-grade, well-differentiated chondrosarcoma developing from an osteochondroma. A bit of an unusual location, but the growth and proliferation of this lesion over whatever decades of time that this patient had this lesion probably account for that. So not a terribly challenging case, but it does bring up the discussion of what factors would lead you to classify something as a low-grade chondrosarcoma. And those are a combination of both clinical, gross, and the cytologic features that we've talked about here. So that's our case number 1. We'll go on here to case number 2, which is much more esoteric case. This is an older gentleman, a 50-year-old man who has had masses on his back that have recurred a number of times over a couple-year period. And so here we can see this lesion. It's certainly at least abutting the deep fascia. We have some skeletal muscle here in this tissue. And we can see there's a nodular, nested appearance to this lesion. Here at the periphery, we can see there is at least some suggestion here of angioinvasion. But interestingly, look here at this, you'll notice that we do have a little rim of endothelium over these buds within the tumor, which is kind of an interesting pattern. Looking at the core of this lesion, you see the appearance is that of a somewhat spindled, somewhat epithelioid tumor with a lot of vacuolization to the cytoplasm. Maybe some of these are little lumina type of appearance. And there's, like this sort of here. There's not a lot of red cells in them, but there certainly is some associated adjacent vessels, as you can see here. So this was a challenging lesion to figure out. When it first came to my attention, it had been previously called an epithelioid hemangioendothelioma. And given the atypia and the apparent vascular nature of this lesion, the appearance and some mitotic activity in this lesion, that certainly seemed like a likely possibility. Now, because there are were some associated or some molecular changes associated with that, we went ahead and did FISH testing to see if we could demonstrate the CAMTA1 fusion gene that is characteristic of epithelioid hemangioendothelioma. And lo and behold, it came back negative. So we had a lesion that was CD34 positive, CD31 positive, FLI1 positive. So it had some of those sorts of features, but was not noted to have the more specific marker for the diagnosis that he'd been carrying. So one of my colleagues got curious about a number of things. One of the things that was noted, however, with the FISH testing for CAMTA1 was that there was amplification of some other genes, copy number gains in some sort of non-specific passenger genes that were around the GLI1 locus. And so the concern was raised as to whether or not this could be a GLI1 rearranged neoplasm of some sort. And so that testing was proposed and indeed ultimately came back positive. Now, the GLI1 rearranged tumors are relatively recently described tumors that have sort of a perithelial type of appearance and can have this sort of a pattern of, growing into vessels as we described over here in a subendothelial type of fashion. Typically, these occur in the head and neck, most frequently in the tongue, but trunk and occasional extremities have been seen, but they've been almost universally described as benign. However, this lesion has a much higher grade cytology. It's not as bland as those lesions that have previously been reported. And so we didn't really feel comfortable just calling this a neoplasm, a benign tumor, because in fact, this patient has had recurrences, developing metastatic disease, and is probably going to succumb to this neoplasm. So this is, best we can tell, a GLI-1 rearranged sarcoma that has begun on the back and now is metastatic to other organs and creating potential risk to this patient's life. So an uncommon variant of an uncommon tumor, that's the kind of sometimes the consequences of living in the zoo, as we say, of an academic medical center with a busy oncology service. So we'll go on to the next case. And this is a subcutaneous mass from a 3-year-old boy. Somewhat rapidly enlarging, but fairly superficial. And this is a lesion that not often we see, because obviously I'm not practicing most of the time in a pediatric setting, although we do have colleagues in our departments who handle the pediatric tumors, and on occasion will share the really good ones with us. But as you can see here, there's a nice nested pattern of these sort of spindle-shaped cells admixed with some fatty tissue, and variable cellular areas and less cellular areas here in this neoplasm. And as we look at some of these cells, you can see there's a bit of foaminess to some of these cells. We'll look over here a little bit more. I think you can actually begin to see occasionally there's a little bit of a lipoblastic appearance as you get a little bit of indentation on some of these cells, some of the nuclei, clearly, fatty component to the neoplasm. So this is a pattern that one should be familiar with, and is really quite characteristic of this lesion, to have this sort of nested, intertwining tumor with a little bit of fibromyxoid background and intervening associated fat, occasional lipoblastic cells. This is a very classic appearance of a lipoblastoma, which not an uncommon lesion in infancy and so forth, but certainly as you get beyond 3 years of age, would be very uncommon to encounter this neoplasm. So if you're in an exclusively adult hospital, you're probably not going to see this, but occasionally you can run across things like this. So our next case going on is a 50-year-old woman who had a solitary mass in the uterus, and we've provided a couple of slides here. You can see here this is a cellular tumor. It's got a little bit of nodularity to it, and I showed you 2 H&E slides. Here's the other one showing a fairly sharply circumscribed lesion. And a lot of sort of hyalinized stroma between these cells. And as we look at them at high magnification, we can see somewhat epithelioid, sort of in cords and strands, with this very hyaline matrix in between the cells. So this is certainly not the typical appearance of a uterine smooth muscle tumor, although obviously we know that epithelioid variants can present in such a manner. So out of interest and so forth, and concern that this could be an epithelioid leiomyosarcoma or something, particularly in light of this earlier area where we have a little bit of budding and so forth off of it, and variable degrees of cellularity here. Here, a higher cellularity area with more cells and more inflammatory cells intervening, as less matrix in this particular area. So we did a number of immunoperoxidase stains, as might be expected in a case of this sort. And here is our Desmond stain, which you can see is strongly positive and confirms a smooth muscle component or a muscular component to this tumor. So this is then a smooth muscle tumor, and we could think then towards an epithelioid tumor. We do also do mitotic counts in a situation like this. And to do that, I, of course, will manually count them, but I oftentimes will use the phosphohistone 3 stain as a means of helping me pick out and distinguish pycnotic cells from truly mitotically active cells. And this is the PHH3 stain, which only stains cells that have exposed the phosphohistone 3. And it's usually it should be a very bright stain. So this pale staining of a few of these cells is not a true mitotic event. And so as you can see, we can scroll through this for great distances, and maybe that's a mitosis there, but they're decidedly infrequent. Maybe another one here. Certainly much less than anything that would put us into the concern of an epithelioid leiomyosarcoma, which can have a lower threshold for mitotic activity than a conventional leiomyosarcoma. So that was comforting and so forth. But to sort of complicate matters, I think one of my colleagues started the workup on this. We also did a couple of other immunostains. So here is, as you can see, some cytoplasmic positivity in this tumor with P16. And that's okay. I mean, I'm not sure exactly why they did, other than maybe thinking that it might be endometrioid lesion. And they also did a P53, which, as you can see here, shows a mutated status. So I show this to illustrate one of the pitfalls you can sometimes get pushed into when you do immunostains of this sort. Because in many leiomyosarcomas, P53 is mutated, and P16 will be positive, indicative of that mutational status. But that's not the criterion for malignancy. In atypical leiomyomas, this feature would certainly lead to more frequent follow-up. But in a lesion that lacks mitotic activity, lacks necrosis, and only has cellularity, the best we could do is say that this is an epithelioid leiomyoma with an aberrant molecular phenotype of P53 mutated status. So we did not call this a leiomyosarcoma or other lesion, but simply signed it out as an epithelioid leiomyoma with an aberrant immunophenotype that was of interest, but doubtful to be of any clinical significance to this patient. So in retrospect, I don't know that I would have done the P53 and P16 staining if I had seen the phosphohistone stain first. I would have just signed it out as an epithelioid leiomyoma and gone on to the next case. But as it was, I had to do some further thinking, some showing it around, and compose a nice note to go along with my diagnosis. Okay, well, not seeing any questions up to this point. Please feel free to jump in with questions if you'd like. Let's go on to the next case, which is, again, moving back into the pediatric side of things. This was a 15-year-old boy who was found to have a mass in the tail of the pancreas. I'm not sure exactly what symptoms led to that discovery, whether it was an accidental discovery, incidental discovery, or something of that sort. It could easily have been that the patient got a CT scan for some other reason, or he may have had some measure of pain. At any rate, he was found to have about a 3-centimeter mass in the tail of the pancreas that had fairly sharp margins, but was certainly concerning for possible neoplasia. And that led to endoscopic evaluation and a transgastric biopsy. So here we can see there's some areas here of normal pancreatic acinar parenchyma, nice lobulated appearance with nice acini and so forth, and nothing of concern there or in that. But then we see a slightly different morphology here. And over here, we can see that these are sort of islands of similar tissue that have sort of fallen apart a little bit. And looking more closely at these, I think you can appreciate that there seems to be a central vessel in several of these, around which you have this sort of almost pseudo-rosette type of an appearance around this little central small vessel. So that's actually almost pathognomonic for the lesion in the sense of the architecture. But of course, there are a number of things that could look like this, I suppose. So you want to think about the other sorts of things that could occur in a pediatric age group. Pancreaticoblastoma can occasionally have rosette-like structures. Neuroendocrine tumors, I suppose, could have a highly vascularized appearance like this. And the more classic lesion, solid pseudopapillary tumor. So this was subjected to immunohistochemical evaluation. And here we can see one of these stains that shows a little bit of positivity in this tumor. And here you can see some of it in the normal tissue. And here, this is, I believe, chromogranin stain. I didn't put the stain. I didn't put the stain on this particular marker. Here is the cytokeratin stain, which, as you can see, is nice and strongly positive in the acinar tissues, but pretty much negative in the tumor tissue. And then here is our pathognomonic test stain. This is the beta-catenin stain. So beta-catenin is considered very helpful in a solid pseudopapillary tumor, since it will be negative in the neuroendocrine tumors. But it also can be positive in pancreaticoblastoma, which is an important consideration as well. And that should be nuclear and cytoplasmic positivity. Here you see the normal parenchyma has just the cytoplasmic membranous pattern of staining, which would not be considered positive or indicative of the CTNB1 mutation that is characterized by this. We also did here's the chromogranin stain, which you can see has just a couple of areas lighting up. And another useful stain in this situation is CD10, which, as you can see here, nicely highlights the tumor cells and has, again, a cytoplasmic membranous pattern, and is appropriately negative in the surrounding tissues and would be negative in most of those other lesions that you're concerned about, such as neuroendocrine tumor and pancreaticoblastoma. Here, in contrast, is the synaptophysin stain. Not a 4+ positive, but certainly you can see we have a nice blush to many of these cells, membranous cytoplasmic staining, and some positive staining in the, well, let's see if the normal acini showed up here. I think we had a normal islet or something down here. But anyway, so that's kind of the lay of the land on this. When this came out and was resected, it was a very classic case and had very little of the discohesive changes. It was almost entirely solid. It's remarkable that the H&E on this was able to pull out as much of this pseudopapillary architecture so nicely on this biopsy. Really a kind of a classic appearance. We're not used to seeing this on, pancreatic needle biopsies. I don't think this was it was usually diagnosed clinically in terms of location and age of the patient. And that's one of the unique features in this case, in that this is a boy, whereas 10 to 1, these tumors arise in women. And he's also rather young. The median age is, mid-30s, and he's 15. So he's well below the median, well out of the realm of the usual male-female demographic. So it's a bit of an unusual case in that sense. All right, well, let's go on to another case here. And we'll turn this over so it looks a little bit more normal here. This is a 59-year-old woman who has biliary type colic. We're looking at a section of her gallbladder. As you can see here, we have just the single muscle layer here of this. And she has evidence here of some chronic cholecystitis. You've got some herniation of her biliary epithelium into the more adventitial layers outside the muscle coat. And so it's important to not to recognize this and to not mistake these type of glands for carcinoma. Even as we know, many biliary cancers can be very well differentiated, but usually this is not a problem. Where I have seen these become really problematic is in the setting of dysplasia. And when you have high-grade dysplasia involving the surface, sometimes that can extend down into these Rokitansky sinuses and crypts and involve these glands, and sometimes even produce a little bit of stromal response, which can be rather deceptive. So with that pitfall in mind, I'm sure you had no difficulty recognizing that in this case, we do have an invasive neoplasm. But I think it's interesting to look at it this in the context of its appearance adjacent to here a benign gland here, and this rather poorly differentiated tumor. So this is kind of an easy differential to distinguish this gland, a benign gland, from these malignant glands that are here outside this. Now, biliary cancers can take a variety of morphologies, and they can be quite well differentiated. They can begin with kind of an adenomatous dysplasia, or they can have a more poorly differentiated appearance, and even sometimes a signet ring or discohesive type cancer. This is more tending towards the latter. This is not particularly an intestinal type. This is more of a biliary type of carcinoma that is relatively poorly differentiated. And here you can see extending deep into the adventitial tissues, clear out to here. Obviously, prognosis is based on stage of these lesions. And this is a cancer that sometimes can be a little bit subtle and difficult to detect if you're not very careful in evaluating the gallbladders that you see. And of course, gallbladder is one of the most commonly removed organs in the body, so pathologists tend to see a lot of them. But if we don't sample areas of mural thickening or areas that look a little bit reddened or different from the other mucosal areas, we could miss a lesion like this. And not infrequently, at least in my career, we have detected gallbladder carcinoma in the form of peritoneal metastases that were occult and unbeknown or undetected in the previously resected gallbladder. So a case of poorly differentiated adenocarcinoma of the gallbladder with relatively minimal amounts of dysplasia, a little bit of an exophytic tumor, and obviously infiltrating into the adventitial fat. Now, once you detect this, of course, you want to go back and further make sure that your margins are good, that you haven't missed any nodes or any surface involvement of the mesothelial surfaces. So for contrast, I thought I would share an additional case or two that illustrate other entities in the differential. And so this is a case that, at least on screening exam, looked like there was a mural mass and could be a potential candidate for carcinoma. And here are several sections from the area of thickening. And you can see we have in the wall these multi-locular cystic spaces. It's a little difficult here to see where the normal mucosa is because it's quite hemorrhagic here. But I think if we go down here, you can see there is a little suggestion here that we've got an epithelial surface. Now, in contrast, these cystic spaces are lined by really quite bland epithelium. There's a little bit of loss of mucin, but there's not high-grade nuclear atypia, and there's not evidence of other sort of budding off or, discohesive small cell groups. So a number of possibilities exist in evaluating a lesion like this. This could be simply a cholecystitis cystica profunda, kind of just very dilated Rokitansky sinuses and so forth in the adventitia. That occasionally will occur. But it looks here as though we have a little bit of distinctive stroma, as you see here. So we have a little bit of this type of stroma. And so we could also then begin to think about other biliary neoplasms that can occur in the gallbladder, such as mucinous cystic neoplasm or intraductal papillary mucinous neoplasias occasionally can present in this situation. So in this situation, I would do probably some careful search to see if we have other areas of characteristic mucinous cystic neoplastic changes. But this stroma pretty well tells us that we're dealing with a mucinous cystic neoplasm. If you were to see a corpora albicantia-like scar as well, you could make that even more definitive. And maybe, well, I don't know if this doesn't quite make it to that. The other possibility would be to do hormone receptor staining, because sometimes that can help you identify that this stroma is hormone sensitive. And of course, this lesion is more frequent in women, but does occasionally occur in men. So I think we could make the diagnosis here of mucinous cystic neoplasm arising in the wall of the gallbladder. And this patient should do very well because there's no high-grade dysplasia, no evidence of an invasive neoplasm associated with this tumor. To further sort of add interest to the discussion here, evaluation of the gallbladder, we sometimes get the situation where they will, on ultrasound, the patient will have biliary colic, and it will look like there's an intraluminal mass. And so this is just a very nice contrasting example of polypoid cholesterolosis. So these little exophytic polyps within the lumen are just engorged with these foamy histiocytes, very bland nuclear appearance, not to be confused with signet ring cell carcinoma or anything like that. But they can reach a size of even sonometers of size and thus be detected ultrasonically and potentially could create problems with biliary obstruction and colic in these patients. So I usually comment on, mucosal cholesterolosis when I see it. And if it's forming a polyp, an exophytic polyp in this manner, I will certainly comment on that to help the correlation with our ultrasonographer friends and so forth. Now, the other thing to note here, again, here's one of these nice dilated Rokitansky sinuses here. As you can see, outside the level of the muscle. Here, it's just a little island of muscle there, but most of this is adventitial tissue. So you can have adenomyosis and dilated Rokitansky sinuses deep in the adventitial tissues, and you can see several of them here as well. This one more completely outside the muscle. Here's another example of mucosal cholesterolosis, just for completeness sake, and you can see some of the complexity to which the biliary mucosa can progress. Okay, we've got a couple more cases. Let me do one more gallbladder case here. This is a case that came to our attention recently. And this is a nice contrasting lesion. This was not a difficult lesion to miss. There was obviously a mass in the lumen and involving the wall. And it's interesting from the sense of the histology here. As we look at the margins of this initially, I think you can see that there's a degree of mucosal dysplasia here. So looking at these cells with enlarged nuclei, prominent nucleoli, this is a nice example of biliary dysplasia. And if this were all you had, then of course you'd want to sample more fully to make sure you didn't have an occult tumor, an occult invasive lesion. You'd want to make sure your margins were free of dysplasia, and so forth. So this is, in contrast to the more normal biliary epithelium over here. You can see the transition here from normal. Bingo, here's the dysplasia. And so this is an important thing to recognize. It can be a little bit subtle here, as you see. But then obviously in this case, we have a progression of that dysplasia into an exophytic tumor here with a somewhat papillary exophytic pattern, still with some fibrovascular cores. And then, as you see elsewhere here, we have a nearly solid pattern of growth with a little bit of residual mucin, some cribriform pattern architecture, and again, very high-grade dysplasia, very high-grade neoplastic change. So the interesting thing about this is that I think this represents this sort of progressive dedifferentiation in these tumors, because as we look near the base of this tumor, you can see there are still some areas where we have this more conventional pattern of glandular differentiation here, and here. And when we did a little bit of immunohistochemical study of this lesion, indeed, these areas were positives for some of the MUC stains, MUC2, MUC5AC, whereas this solid, more cribriform component, maybe even hepatoid, you could say, did not. Now, this did not stain for any hepatic markers, so it was not a combined cholangio hepatocellular carcinoma, but it does show this evidence of progressive dedifferentiation. There are a variety of other morphologies that can occur in the gallbladder. You can get small cell carcinomas, you can get signet ring, pure mucinous carcinomas, and so forth. So it's a really a widely varied morphology that you can see in the carcinomas of the gallbladder, and I think makes for a challenge to pathologists who don't see gallbladder carcinomas very frequently. Maybe in your career you'll see a couple, even though you're examining gallbladders every week at least. But the morphologies are out there, the variants do exist, and being aware of some of that and some of the pitfalls that we've described is a very important thing to be aware of. So just to broaden and diversify your exposure to gallbladder carcinomas and gallbladder lesions, I thought I'd present these several related tumors today. Our last case is, let's see, the history here on this was an older man who had developed anemia. And of course, he had microcytic hyperchromic features, which meant blood loss, which meant that he got a GI workup. And in doing the lower GI workup, he was discovered to have 2 lesions in the more distal sigmoid, rectosigmoid area that were somewhat exophytic, as you can see here, and did not have normal GI architecture. You can see we've got ulcer debris and so forth, but we don't have any evidence of glands in this lesion. A lot of it's just ulcer debris. As you can see, ulcerated tumor. But there were these occasional little islands of neoplastic cells. And you can see why he was anemic. He's bleeding from this. There's a lot of vessels, thrombosis, and so forth here. But from a pathologist standpoint, we're at this point less interested in the bleeding and more interested in what's going on here that's altering the vasculature and causing him to bleed. So here's a fairly solid-looking tumor. In this area, we'll look at the other section here as well. Here, just sort of ulcer debris with bacterial colonies and so forth. And here, more of this tumor, altered vasculature and so forth. So as I look at this, a couple of things come to mind. Because we had 2 lesions that were like this, I'm not thinking primary colorectal carcinoma. In addition to the fact that, this just doesn't look like that. There certainly are colorectal tumors that could have this kind of very poorly differentiated appearance and so forth, but usually not in more than one site at the same time. And those would include things like medullary carcinomas and so forth. But then we start to think about, well, if he's got multiple lesions, maybe this is metastatic tumor. And what are the metastatic tumors that can present in the colon? And there's really quite a long list. Certainly breast cancers are one of the more frequent ones in women and occasionally in men. And they can occur long after the fact. Lobular carcinoma is notorious for having a late metastatic disease that can present in the wall. This doesn't look like lobular carcinoma. We're not thinking of that in this circumstance. Renal tumors, ovarian tumors, prostatic tumors. This is a very high-grade lesion, of course. And then melanoma. Melanoma, in fact, has a real penchant for metastasis to the bowel and should be considered in any lesion because it can affect small bowel, large bowel, occasionally even stomach as a secondary site. And again, can occasionally occur as a late metastasis from potentially even an unknown or undiagnosed primary cutaneous lesion if the patient had a regressed melanoma or had a lesion excised and not examined. So in fact, this turned out to light up very brightly with SOX10 and with pan-melanoma markers, was negative for cytokeratins and so forth. And in making the diagnosis of melanoma, we were able to firm that up and also provide some instruction in terms of what sort of management would be appropriate. In fact, oligometastatic melanoma is amenable to surgical treatment, and resection of limited number of metastases in GI metastases in melanoma does in fact lead to a prolonged lifespan compared to patients who do not undergo treatment or resection. So we were able to provide some helpful guidance to the surgeons in that regard, as well as the diagnosis, and they will plan to resect it, assuming the patient's a suitable operative risk. Well, we've gone through quite a number of slides, some interesting mixture of cases, and I appreciate you joining me on this St. Patrick's Day. I don't see that we have any Irish on board for the discussion here today, but I'm glad that you could be with me, and I hope that this has been helpful for you. Any comments or questions that any of you want to bring up? We will, of course, post the recording of our session today later on, and that'll be available for you to review if you want to come back. Along with that, I'll include the link to the slides, which you, of course, have already had the chance to review. And you can certainly feel free to use those in your teaching or other interactions with your colleagues. All right, well, thank you all, and we will see you again next month. Have a wonderful day.